Hi there, my name is Anna Shah. I'm one of the neurologists at the Rocky Mountain MS Center at the University of Colorado. We're going to do a quick talk about the differences between relapses and pseudo-relapses in patients with MS. So let's dive right in. Okay, sorry. Okay, so let's look at relapses versus pseudo-relapses. So that purple box I outlined right there on the left. So what is a relapse? And this becomes really important because most primary care doctors are probably going to hear from their patients with MS or might see their patients with MS in a more easily accessible fashion than their neurologist may be, because their neurologist may be hours or even states away. So MS relapses are new neurologic symptoms lasting more than 24 hours, and they typically have a subacute onset. So onset over days to weeks. I would not think something is an MS relapse if patients are saying, I did not have this 1 minute and the next minute it was there. That I would kind of think about being more acute, like things like ischemia or stroke related. Now, MS relapses should always be associated with a new lesion that is enhancing or gadolinium positive on an MRI scan. What kind of symptoms can a person with MS experience when they're having a new relapse? And it can really be a variety of different things. So things that they can experience include double vision, loss of vision in one eye, where the movement of that eye itself is painful. This is optic neuritis. They can have new loss of sensation. This can be in one arm or one leg, or commonly if there's a spinal cord lesion, they can have loss of sensation in both legs up to a certain level on either their abdomen or trunk. They can have a new change in walking, new difficulties with walking in terms of balance, things like that. Fatigue can actually sometimes get worse with MS relapses. One of the things that we don't really quite understand is where is it that's causing fatigue in MS? So sometimes if MS patients are getting multifocal new areas of inflammation, the way they might show up, especially if it's in areas where there's redundancy of neural circuitry, they might just show up with extreme fatigue. Weakness is a common symptom that we see in individuals that have new spinal cord lesions, whether it's in the cervical or thoracic spine. We can sometimes see changes in bowel or bladder function, especially incontinence in that early period. Vertigo is one. Muscle spasticity is not a typical one that we expect with relapses, but can occur. Changes in mood, I sometimes tie that back to what we kind of experience with fatigue if people have multifocal new inflammatory disease, and that also ties in with that change in cognition. And then let's think about the other side of the coin. What is recrudescence? So recrudescence is similar to what we say when we say pseudo-flare. As an MS neurologist, I much prefer the term recrudescence as opposed to pseudo-flare. I think pseudo-flare gives patients the idea that these symptoms are not real since it's got that pseudo in it. So I prefer the term recrudescence, but they are essentially the same thing. And this is recurrence of prior neurologic symptoms. And with this, if we obtained new MRI scans and we gave them contrast or dye through it, we would not see any new lesions or anything that looks bright. Now, this in MS patients can happen anytime body temperature is increased. So there have been some studies published that show that even just a 1/4 degree increase in body temperature can cause these prior neurologic symptoms to re-flare. So things like infections, fevers, exercise, heat, stress, all of those can cause recrudescence. The key takeaway from this is recrudescence does not mean there's new inflammatory disease activity. It does not need steroids. It does not need a change in their treatment for MS, but what it does need is treatment of whatever is causing it. So I'll give you an example. I often will hear if I said I was a patient with MS that had optic neuritis in my right eye, and the way that it showed up was my vision was quite blurry. Perhaps every time I exercise and every time I get my body temperature up, my right eye might go blurry. And then as I stop exercising, I'll allow my body temperature to cool down, my right eye might clear up. So in that case, that doesn't mean I'm having new damage to my optic nerve, or I don't need steroids, or my medicine's not working, but it might just mean perhaps I need to figure out how to stay cooler when I'm exercising so I don't get these pseudo flares or recrudescence. How do you decide if it's one versus the other? And this can sometimes be easier said than done. So just like everything, clinical history becomes incredibly important. Have they had this symptom before is probably the most important question. If it's a symptom they've never had before, by definition, it cannot be recrudescence. Are there triggers? How long do symptoms last? And are they taking their MS medications regularly? Depending on where they are treated and based on what medicines they are, there's some that are oral medications that are taken every day. There are some injections that are taken every day, versus there's some infusions that are done once a month. They're done once every 6 months. So it's really important to make sure that they are taking their medicine the way it's prescribed. Another thing that could help us determine whether it's relapses versus recrudescence is to obtain imaging. So getting scans with contrast, with gadolinium, are incredibly helpful. Now, gadolinium, or the contrast that we use in MRI scans in the setting of MS lesions, will show us if something is new or acute in terms of MS lesions for up to 8 to 12 weeks after it starts. So unless the patient started having new symptoms over 2 to 3 months ago, I would expect a lesion to show up as bright if it's new inflammatory activity. Depending on what their lesion is or what their symptoms are, it would depend. It might be important to just get the brain versus getting the brain and cervical spine, or brain, cervical, and thoracic spine. The good news is you can always reach out to their neurologist that they're seeing to see which one of these images would be best based on their symptoms. Lumbar spine imaging is usually peripheral nervous system. So the lumbar spine images mostly the cauda equina and the nerve roots. By definition, it's not part of the central nervous system, so therefore cannot have new lesions there that are causing relapses. So lumbar spine imaging is not needed. This is probably the most important piece of all of this, is patients with MS can always have non-MS related pathology. So don't forget to think about other differential diagnoses. And if it is a relapse, what do we do? So the mainstay of treatment typically is steroids. And now the intention of steroids are not to impact the long-term picture. The utilization of steroids is really to decrease the duration of the symptoms and how long they last. They do not have any effect in terms of long-term prognosis. So an example of this might be if I had 2 individuals with optic neuritis and I gave one steroids and not the other. The one that got steroids might have a shorter degree or a shorter length of the symptoms with their optic neuritis, but looking at them a year out, I would not expect a change in how much visual recovery they had. They can be appropriate in certain circumstances, so I typically will dose them when they are symptoms that are bothersome to the patient. So for example, if a patient has a new relapse, is causing difficulty with walking, well, gosh, having a shorter duration of symptoms certainly would be helpful there. Now, if it's a patient that says, I'm having a new relapse and it's numbness, perhaps in the index finger, in that setting, I might say, well, how bothersome is this? And do we need to subject you to long-term implications from steroids if the symptoms aren't necessarily that bothersome? There are different ways to go about prescribing patients steroids, but they usually require high dose steroids daily for about 3 to 5 days. A prednisone burst pack will not be enough in terms of steroid requirement for MS relapses. So if IV steroids are utilized, that's usually 1 gram of solumedrol daily for 3 to 5 days. And oral steroids can actually be utilized with the same efficacy as the IV steroids. Now, the oral steroid equivalent is quite a lot, so we typically will use prednisone, 1,250 milligrams of prednisone to be specific, The way that that is prescribed is it's 25 50-milligram pills of prednisone taken daily. Now, of course, there's patients that are probably more ideal for this than others, but making sure a patient understands that this would all have to be taken 25 pills per day for 3 days. So in patients that have dysphagia or things like that, that might not be an appropriate situation for that patient. It is considerably more cost effective to go ahead and do the oral steroids than the IV steroids. It's also a lot more helpful, especially if you're coming up on a weekend and infusion centers aren't available. And of course, the primary neurologist that's taking care of this patient is always there to help. So please do not feel like you have to do this alone. We also talk about symptomatic management with relapses. For example, if someone is having double vision, perhaps offering them a patch so they're not consistently seeing double, or if someone is having new difficulties with walking, making sure that they have the appropriate durable medical equipment available to help them get around safely.